So picture this. A 55-year-old woman walks into your clinic.
Okay.
She has literally never touched a cigarette in her life. She eats well, she exercises, absolutely no family history of cancer, and she's just there for a persistent dry cough. You know, she thinks it's just lingering from a winter cold.
Right, very common.
Yeah. But then you put her x-ray up on the light box, and there's this jagged white shadow sitting right in the periphery of her right lung.
Yeah.
A shadow that could kill her. So welcome to today's deep dive. We are exploring the really terrifying reality that 1 in 5 lung cancer patients looks exactly like her.
It completely shatters the traditional paradigm, honestly. I mean, when you're standing on the wards, especially as a PA student, your brain is it's hardwired by textbooks to associate lung cancer exclusively with like a 70-year-old chain smoker.
Right.
But if your index of suspicion drops just because the patient in front of you doesn't fit that exact stereotype, you're going to miss the most lethal malignancy in the United States.
And that is exactly our mission today. We are completely bypassing the casual overview, folks. This is a comprehensive graduate-level clinical masterclass. It's built specifically for you, the physician assistant student preparing for your clinical rotations and your board exams.
Absolutely.
So we are using this incredibly detailed clinical slide deck authored by Graceline Seppo, a PAC with advanced degrees in medicine and surgery. And it covers everything. I mean, molecular pathophysiology all the way to stage-based management.
It's a fantastic resource.
It really is. So I'm going to be sitting here in the learner's seat, asking the questions, dissecting the why and how behind the pathology, and you are going to be our seasoned attending pulmonologist oncologist today.
I am ready. You know, we really need to build your clinical reasoning here. We aren't just memorizing lists of symptoms today.
Right.
We are going to reverse engineer the disease.
Yeah.
That way, when a patient presents with confusing or overlapping signs, you can actually trace it back to the cellular level, know exactly what to do.
That sounds perfect. Let's start by unpacking that opening scenario, actually, because that patient profile, the non-smoking Asian American female, it's actually a massive board-relevant demographic.
Oh, massively, yeah.
The data shows they account for over 53% of lung cancers among non-smoking women. That's more than double the rate of white women in that same category. So what is actually happening at a biological level there?
It all comes down to molecular biology, specifically an EGFR mutation.
Okay, EGFR.
Yeah, epidermal growth factor receptor. So in a normal cell, EGFR is basically like a switch, right? It tells the cell to divide and grow.
And then it turns off.
Exactly, it turns off. But in this specific demographic, there's a very high prevalence of a genetic mutation that essentially jams that switch in the on position.
Oh, wow.
Yeah, so the cells just replicate uncontrollably, and that forms an adenocarcinoma.
Okay, so if I'm on my oncology rotation, why does knowing that precise genetic mutation actually matter for my treatment plan? I mean, doesn't she just get standard chemotherapy like everyone else?
No, she doesn't, and that is a crucial clinical pearl for the boards.
Okay.
Traditional systemic chemotherapies, well, it's like carpet bombing the body, right?
Right.
It kills any cell that is rapidly dividing. That's why patients lose their hair and, the lining of their gut.
Yeah, that makes sense.
But if you biopsy her tumor and you identify that specific EGFR mutation, you can use targeted oral therapies, tyrosine kinase inhibitors.
Tyrosine kinase inhibitors.
Exactly. These drugs are like precision-guided missiles. They only target the broken EGFR switch. So her prognosis improves radically. And this is the key, you only find it if you know to look for it.
Wow. Okay, that makes complete sense. You have to treat the specific biology, not just the symptom.
Exactly.
But let's zoom out for a second and look at the sheer scale of this disease, because the statistics from the slides are genuinely hard to process. Lung cancer is the #1 cause of cancer death in the U.S. for both men and women.
#1.
It kills more people than breast, colon, prostate, and pancreas cancers combined.
Combined, yeah. It really does. And the distinction you need to make for your exams here is the difference between incidence and mortality.
Okay, break that down for me.
So we actually diagnose more cases of breast cancer and prostate cancer every single year. Their incidence is higher.
Oh, I see.
Yeah. But the overall 5-year survival rate for lung cancer is just this grim 15%. Mortality-wise, it is the undisputed apex predator of oncology.
But why, though? I mean, anatomically speaking, is the lung just a terrible place to get cancer, or are we just really bad at finding it early?
It's largely an anatomical trap. So the visceral pleura and the lung parenchyma itself, they do not have pain receptors.
Wait, really? No pain receptors at all?
Practically none inside the lung tissue itself. So you can literally have a tumor the size of a golf ball growing right there in the right lower lobe, and the patient feels absolutely nothing.
That is terrifying.
It is. And furthermore, the lungs have a massive functional reserve capacity. You can lose a significant portion of your lung volume before you ever even feel short of breath at rest.
So by the time a patient actually feels sick enough to book an appointment with a PA, like by the time the tumor invades a structure that does have pain receptors or it obstructs a major
The
airway.
disease has already packed its bags and metastasized.
Right. Wow.
Exactly. It's a silent killer. And look, while we just discussed the non-smoker paradox, we absolutely cannot ignore the dominant driver here. Roughly 90% of all lung cancer cases are directly caused by smoking.
Right. The highest risk group is defined as adults between 50 and 80 years old with a smoking history of more than 20 pack years.
Correct.
And just to skip the basic math for everyone listening, we know a 20-pack year is a pack a day for 20 years, or 2 packs a day for 10 years.
Yeah.
But I really want to focus on the secondhand smoke data here because this is fascinating to me. The notes say side stream smoke. That's the smoke curling directly off the burning tip of the cigarette, right?
Yes, exactly.
It says that is significantly more dangerous than the smoke the smoker actually exhales. Why is that?
Think about the physics of a cigarette for a second. When a smoker inhales, they pull oxygen through the tobacco, right? Which causes it to burn at a very high temperature. And then that smoke passes through a filter.
Right.
But when the cigarette is just sitting there in an ashtray, it's smoldering at a much lower temperature.
Yeah.
And that low-temperature combustion creates a completely different, highly concentrated chemical profile of carcinogens.
Oh, wow. I never thought about the temperature difference.
Yeah. Plus, it is completely unfiltered. So imagine a bartender working in a smoky room for 20 years. They're inhaling pure, unfiltered, highly toxic side stream smoke for hours on end.
Which explains why cohabitation with a smoker increases your risk by 30% and workplace exposure by 20%.
Exactly.
Actually, let's pivot to the workplace for a minute. Environmental and occupational toxins. Say I have a 50-year-old man in my clinic. He works in a shipyard, and he smokes 2 packs a day.
Okay.
And he asks me about his lung cancer risk compared to his neighbor who doesn't smoke and doesn't work at the shipyard. How do I quantify that for him?
You explain the concept of synergistic risk. This is a vital concept for the boards. The risk isn't additive, it's multiplicative.
Okay.
So if you have a non-smoking asbestos worker, their mortality ratio is about 5.17 times higher than the general population.
Right.
Now, a smoker with no asbestos exposure is around 10.85.
So intuitively, you'd think, okay, 5 plus 10, his risk is about 15 times higher.
Exactly, but biology doesn't work like that. The asbestos fibers create chronic inflammation and microscopic scarring in the lungs. Then, the tobacco smoke introduces these intense chemical carcinogens. Together, they act synergistically.
So what's the actual number?
That smoker with asbestos exposure has a mortality risk ratio of 53.24.
53.
Yes. It is an astronomical jump.
And here is a classic board trap I want to highlight for everyone listening. When we hear the word asbestos, our brains immediately go to those late-night legal commercials for mesothelioma.
Right. Do not fall for it on the boards.
Okay, why not?
While mesothelioma is uniquely and almost exclusively linked to asbestos, it is actually quite rare. The most common lung malignancy associated with asbestos exposure is actually just standard bronchogenic carcinoma.
That is a phenomenal pearl. Bronchogenic carcinoma is #1 for asbestos. Okay, what about the environmental toxins we don't choose, like air pollution? The slides mentioned PM 2.5, that's particulate matter from burning fossil fuels, right?
Sure, okay, sure.
How exactly does dirty air turn a perfectly healthy lung cell into a cancer cell?
It's basically a combination of physical damage and genetic sabotage. So PM 2.5 particles are microscopic, less than 2.5 microns in diameter.
So they're tiny.
Tiny. They're so small they bypass all the mucociliary escalators in your upper airway and penetrate deep, deep into the terminal alveoli. Once they're down there, your macrophages try to consume them. But they can't break down heavy metals or polycyclic aromatic hydrocarbons. So this triggers a perpetual state of chronic inflammation and oxidative stress.
It's sort of like a microscopic splinter that the body can never push out?
Precisely. That's a great way to think of it. And that constant oxidative stress leads to the formation of DNA adducts.
DNA adducts.
Yeah, a DNA adduct is when a cancer-causing chemical covalently bonds directly to a segment of DNA. It's like someone dropping a glob of ink on a recipe book.
Oh, that's a good analogy.
Yeah, so when the cell tries to replicate and read that DNA sequence, it misreads the code. This leads to mutations in critical tumor suppressor genes, like p53. And once p53 is knocked out, the cell loses its ability to undergo apoptosis, programmed cell death.
And carcinogenesis begins. And that perfectly bridges into the social determinants of health, I think. Because who's breathing that PM 2.5? It's not usually the wealthy executives in tent houses. It's the underserved communities living right next to the highways, the refineries, the industrial zones.
Yes, the built environment plays a massive, tangible role in oncology. Lower income correlates with higher environmental toxin exposure, higher tobacco use, and crucially, delayed access to screening.
Right.
You might be a brilliant diagnostician, but if your patient couldn't afford to take a day off work for a screening CT scan 3 years ago, you are now trying to treat a metastatic stage 5E disease instead of a curable stage I nodule.
Wow, yeah. Let me play devil's advocate here, though, for a second.
Sure.
We established that smoking is the driver for 90% of cases, but biologically speaking, only about 20% of heavy smokers actually develop lung cancer in their lifetime.
That's true.
If tobacco is such a potent carcinogen, why don't 100% of chain smokers get it? I mean, is it just genetic luck?
It's a brilliant question. It really comes down to genetic variability and competing mortality.
Competing mortality. Okay.
Yeah. So genetically, we all have different deficiencies in our hepatic cytochrome P450 enzymes. Those are the enzymes that detoxify chemicals in the liver.
Right, the liver's cleanup crew.
Exactly. Some people clear carcinogens quickly, others don't. Furthermore, some people have highly efficient DNA repair mechanisms that fix those DNA adducts before the cell even replicates.
And the competing mortality aspect.
Well, tobacco systematically destroys the entire vascular and respiratory systems. A huge percentage of heavy smokers simply do not live long enough to develop the genetic mutations required for lung cancer.
Oh.
Yeah, they die of a massive myocardial infarction or a stroke or end-stage COPD, like a decade before the cancer would have clinically manifested.
That's incredibly grim, but it makes total sense. Okay, so knowing that late-stage lung cancer is practically a death sentence, the entire game here is about catching it early. Let's talk screening.
Yes, screening.
The USPSTF guidelines. This is absolute gospel for the boards and for primary care.
You must know this, Gold. If you take nothing else away, know this. We screen using an annual low-dose CT scan, or LDCT.
Okay. And what are the criteria?
The criteria are adults aged 50 to 80 who have a 20-pack year smoking history and who currently smoke or have quit within the past 15 years.
Okay, wait, why the 15-year cutoff for quitting? Like, if I quit 16 years ago, are my lungs just suddenly immune to cancer?
No, not immune, but the risk profile drops significantly. After 15 years of smoking cessation, the continuous inflammatory cascade is largely resolved, and those damaged epithelial cells have had time to turn over.
I see.
Yeah, so the risk of developing a new primary lung cancer drops to a level where the radiation exposure from an annual CT scan, plus the anxiety of false positives, actually outweighs the statistical benefit of finding a tumor.
And we also stop screening if they develop a comorbidity that limits their life expectancy, right? I mean, if a 75-year-old has severe class 4 heart failure and wouldn't survive a surgical lobectomy anyway, screening them for lung cancer doesn't really offer a path to a cure. It just gives them a new diagnosis to worry about.
Correct. Screening must be tied to the intent and ability to cure. And when we do screen properly, it works. The National Lung Cancer Screening Trial showed a 20% relative reduction in mortality with low-dose CT versus standard chest x-rays.
Huge difference.
Huge.
All right, so let's step into the radiology reading room. We do the CT scan, and we find a spot. A solitary pulmonary nodule, an SPN. Where is the line drawn between a benign little freckle on the lung and a massive red alert? The slides mention a golden rule of 30 millimeters, 3 centimeters.
Yes. A nodule is strictly defined as a well-circumscribed lesion less than or equal to 3 centimeters, and it has to be entirely surrounded by aerated lung parenchyma.
But why 3 centimeters? What is happening biologically at, say, 31 millimeters?
It's all about angiogenesis and tumor biology. For a mass of cells to grow beyond 3 centimeters, it can't just rely on passive diffusion for oxygen and nutrients anymore.
It needs a blood supply.
Exactly.
Right.
It must establish its own robust, chaotic vascular network. And once a lesion crosses that 3-centimeter threshold, its biological behavior fundamentally changes. It is no longer a nodule. It is a mass S. And the rule you must sear into your brain for the wards is a lung mass is considered malignant until proven otherwise.
Okay, but let's say it's only 1.5 centimeters. It's just a nodule. I'm looking at the imaging. How do I know if this spot is a cancer starting to grow or just like a scar from a bout of pneumonia 10 years ago?
We look at the margins and the calcification patterns. Benign lesions are usually smooth, round, and well circumscribed. They don't look like they're invading.
Okay.
The calcification is the real key, though. If you see dense central calcification or laminated rings, it's reassuring.
I actually have a vignette from the notes that perfectly illustrates this. Say I have a 45-year-old non-smoker with a routine x-ray showing a 1.5 centimeter nodule. The patient brings in an x-ray from 3 years ago, and the nodule is the exact same size. And a follow-up CT shows it has popcorn calcifications.
Ah, okay. You've just described a pulmonary hamartoma.
Popcorn means hamartoma.
The popcorn calcification is pathognomonic for it. Hamartoma is basically just a benign, disorganized overgrowth of connective tissue, cartilage, and fat.
Ah, okay.
The fat density is what creates that popcorn appearance on the scan. But the other massive clue in your vignette is the radiographic stability. If a nodule is radiographically stable for 24 months, it is overwhelmingly likely to be benign. Cancer grows, it doesn't stay the exact same size for 2 years.
Right, right. On the flip side, what does a malignant nodule look like?
It looks aggressive. You will see spiculations, these jagged sunburst-like projections radiating out from the center.
Cold spikes.
Exactly. That is the tumor physically invading the surrounding lung tissue. You might also see an irregular contour or eccentric calcification, where the calcium's just pushed off to one side because the tumor is growing asymmetrically. Oh, and upper lobe locations are statistically much more suspicious for malignancy.
Okay, so we've established this 3 centimeter threshold in the radiology reading room, but what is happening in the waiting room? How does the patient actually look when that nodule turns into an invading mass? Let's contrast two classic presentations you'll see on rotations.
Let's do it.
Okay, case 1, the incidental finding. A 60-year-old male smoker without a single symptom is sitting on the exam table. He is just there for a pre-op clearance for a knee replacement.
Okay.
You get the routine chest x-ray, and boom, there is an upper lobe solitary pulmonary nodule. What is the next best step? Do I just send him straight to a thoracic surgeon to cut it out?
Absolutely not. You don't jump to surgery, and you don't even jump to a biopsy yet.
Oh, really?
Nope. The next best step for an incidental SPN on an X-ray is a high-resolution CT scan of the chest with IV contrast.
Okay, why contrast?
Because you need to characterize the margins, the density, and the exact size in 3D before you poke a hole in his chest. You have to see the vascularity. This case represents the roughly 75% of SPNs that are asymptomatic.
Okay, now, case 2, the red flags. A 66-year-old retired construction worker with a 45-pack year history. He comes in complaining of a 20-pound unintentional weight loss over 3 months. He's exhausted, his chronic cough has changed, and now he is coughing up streaks of blood hemoptysis.
Right, so this is the symptomatic 25%, and it almost always indicates advanced, likely invasive disease. The cough is the most common symptom, present in up to 74% patients.
And the blood.
The hemoptysis occurs because the tumor is actively eroding into the highly vascular mucosal lining of the bronchi, the weight loss and fatigue. That represents cancer cachexia, the systemic metabolic drain the tumor is placing on the patient's entire body.
The slides also mention recurrent post-obstructive pneumonia. The mechanism here is fascinating. It's essentially like a dammed river, right?
That's a perfect analogy. If a tumor grows inside the lumen of a main bronchus, it literally blocks the normal flow of air and mucus. So the mucociliary escalator can't sweep debris out anymore.
So it just backs up.
Yeah, the lung segment distal to the tumor becomes this stagnant swamp. Bacteria breed, and the patient gets pneumonia. You give them antibiotics, they feel a bit better, but because the dam is still there, the fluid accumulates again and the pneumonia comes right back.
Wow.
If you have a patient with recurrent pneumonia in the exact same anatomical lobe, your alarm bells for a malignant obstruction should be deafening.
Let's talk about the weird systemic symptoms now. The slides mention hypertrophic pulmonary osteoarthropathy. I know digital clubbing is a sign of chronic hypoxia, but this sounds much more severe.
It is. Hypertrophic osteoarthropathy is this intense inflammatory reaction of the periosteum, the connective tissue wrapping the bones.
Right.
It particularly affects the long bones of the legs and forearms. Patients present with severe, deep bone pain. If you order a bone scan, you will actually see symmetrical, patchy radiotracer uptake along the cortical margins.
So it looks like bone cancer.
It looks exactly like a bone metastasis, but it isn't. It's a perineoplastic inflammatory response triggered by the lung tumor.
Perineoplastic syndromes are basically the tumor acting like a rogue endocrine gland, right?
Yes, exactly.
We're going to dive deep into those when we hit histology in a second. But first, there is a very specific high-yield tumor location that causes a totally bizarre presentation, the Pancoast tumor.
Oh, yes. Also known as a superior sulcus tumor.
Mm.
These tumors grow in the extreme apex, the very top of the lung. And because they're at the top, they don't immediately cause coughing or shortness of breath. Instead, they grow upwards and crash right into the thoracic inlet.
I have a vignette for this. A patient comes into the clinic complaining of severe right shoulder pain radiating down the inside of his arm. On physical exam, you notice his right eyelid is drooping, his right pupil is constricted, and the right side of his face is completely dry. No sweat at all.
That is Horner syndrome, combined with a brachial plexopathy. It's the classic Pancoast presentation.
Okay, walk me through the anatomy of why a lung tumor causes a droopy eyelid. That sounds like a massive neurological disconnect to me.
It's actually a direct anatomical chain reaction. So, just above the apex of the lung lies the perivertebral sympathetic chain, which includes the stellate ganglion.
Okay.
This ganglion controls the sympathetic fight or flight nerve signals to the face. When the Pancoast tumor invades and destroys the stellate ganglion, it completely cuts off that sympathetic supply.
Hence the Horner's triad: ipsilateral ptosis, meiosis, and anhidrosis.
Exactly. The eyelid droops. That's the ptosis, because the sympathetic cone keeping it open is just gone.
Right.
The pupil constricts meiosis because the sympathetic dilator muscle is paralyzed, which leaves the parasympathetic constrictor unopposed. And the face stops sweating anhidrosis because the sweat glands literally lose their nerve supply.
And what about the shoulder and arm pain?
That happens because the tumor is simultaneously compressing the C8 and T2 nerve roots of the brachial plexus.
Man, it's an incredible example of why we have to examine the whole patient, not just the lungs.
Exactly.
Okay, so we found the mass, we've seen the symptoms, now we have to biopsy it. And this is where the entire treatment pathway forks. We are looking through the pathologist's lens at the cellular architecture now. We must distinguish between non-small cell lung cancer, or NSCLC, and small cell lung cancer, SCLC.
Let's start with the big category. Non-small cell makes up about 85% of all cases, and it is divided into three main histological subtypes: adenocarcinoma, squamous cell carcinoma, and large cell carcinoma.
We touched on adenocarcinoma earlier with our opening case. It's the most common type overall and the most common in non-smokers.
Yes. From a histological standpoint, adenocarcinoma arises from the alveolar type 2 pneumocytes, the cells that normally secrete surfactant.
Right.
Under the microscope, you will see a glandular formation or mucin production. And anatomically, it typically presents as a peripheral nodule or mass.
Next up is squamous cell carcinoma, making up 20 to 25%. Let's throw out a vignette for this one. A 65-year-old male heavy smoker presents to the ER with acute confusion, severe abdominal pain, and constipation. A chest CT shows a massive, centrally located lung mass. Labs reveal a critically elevated serum calcium level.
This is a textbook presentation of squamous cell carcinoma.
Okay, let's break down the why. Why is it centrally located, and why on earth is his calcium through the roof?
Well, squamous cell arises from the epithelial lining of the major proximal bronchi. That's why it's central. Under the microscope, the pathologist looks for two specific hallmarks: keratin pearls and intercellular bridges.
Intercellular bridges.
Yeah. Because squamous cells are essentially the skin lining the airways, they have to withstand constant friction. So they lock together tightly using these intercellular bridges called desmosomes. When they mutate into cancer, they actually retain those tight little locks.
Oh, that makes sense. And the high calcium.
That is its signature perineoplastic syndrome.
Uh-huh.
Squamous cell tumors frequently secrete PTHrP, parathyroid hormone-related peptide.
Right.
This rogue peptide mimics normal parathyroid hormone perfectly.
Mm.
Travels to the bones, stimulates the osteoclasts, and tells them to break down bone tissue, dumping massive amounts of calcium right into the bloodstream.
Which gives us the classic hypercalcemia mnemonic: stones, bones, groans, and psychiatric overtones. Kidney stones, bone pain, abdominal groans from constipation, and confusion.
Exactly. Central mass plus hypercalcemia almost always equals squamous cell on the boards.
The third non-small cell type is large cell carcinoma.
Yeah, a large cell is essentially a diagnosis of exclusion. It's typically peripheral, but it's highly undifferentiated. The pathologist looks at it and says, well, it doesn't have the glands of an adenocarcinoma, and it doesn't have the keratin or desmosomes of a squamous cell.
So just a generic aggressive cell.
It's an aggressive null phenotype,
Yeah.
and it is occasionally associated with unusual endocrine manifestations like gynecomastia in men, but that's less common.
Okay, so that's the 85%. Now we look at the terrifying 15%. Small cell lung cancer. What is the profile here?
Small cell is the most aggressive, fastest growing lung cancer, and it metastasizes incredibly early. It is almost exclusively found in heavy smokers. And like squamous cell, it is centrally located. Under the microscope, it just looks like sheets of small, dark blue cells with very little cytoplasm.
The slides note that these cells are neuroendocrine in origin. What does that mean functionally?
It means they originate from Kulczycki cells, which are part of the diffuse neuroendocrine system. Because of this, small cell tumors are essentially rogue hormone factories.
Oh, I see.
Yeah, they stain positive for neuroendocrine markers like chromogranin, synaptophysin, and NCAM. And this neuroendocrine nature leads to a devastating array of paraneoplastic syndromes.
Let's hit the 3 must-knows for the boards then. First vignette. A 70-year-old male smoker with a central Hiller mass presents with profound lethargy. His serum sodium is critically low at 115.
That is SIADH syndrome of inappropriate antidiuretic hormone.
Okay.
The small cell tumor is ectopically secreting ADH. The kidneys respond by absorbing massive amounts of free water, which dangerously dilutes the sodium in the blood.
Second syndrome. The tumor secretes ectopic ACTH.
ACTH normally comes to the pituitary and tells the adrenal glands to make cortisol. When the lung tumor pumps it out, the patient develops profound Cushing syndrome, rapid weight gain, moon phases, a buffalo hump, and severe hyperglycemia.
Third vignette, and this one is wild. A 68-year-old male smoker with a new central lung mass complains that he can barely climb the stairs at his house anymore, and he struggles to even stand up from his recliner. He has severe proximal muscle weakness.
That is Lambert-Eaton myasthenic syndrome.
Wait, I'm genuinely confused here. If the cancer is a solid mass in the lung, why is the patient's major symptom muscle weakness in his legs? That seems like a massive friendly fire incident by the immune system.
Friendly fire is the exact mechanism. It's a phenomenon called molecular mimicry.
Molecular mimicry.
Right. The patient's immune system detects the small cell tumor and generates antibodies to attack it. Unfortunately, the proteins on the surface of the tumor perfectly mimic the presynaptic voltage-gated calcium channels at the neuromuscular junction.
So the antibodies cross-react, they travel to the nerves and block those calcium channels instead.
Yes. And without calcium entering the presynaptic nerve terminal, the nerve cannot release acetylcholine into the synapse. The muscle never gets the signal to contract. Hence, profound proximal muscle weakness.
Okay, before we move to staging, I want to share a mnemonic to keep the location straight because it's a guaranteed board question. Think of the letter S. Essential cancers are small cell and squamous cell. Both start with S, both are central. That means adenocarcinoma and large cell must be peripheral.
It's simple, it's high yield, and it works perfectly. S for central, small, and squamous.
All right, we know the histology. Now we need to map the beast. Diagnostic evaluation and TNM staging. How do we actually extract the tissue from the patient to give to the pathologist?
It depends entirely on whether it's an S cancer, central or peripheral. For central lesions sitting in the major airways, we can sometimes just use simple sputum cytology. If a patient gives 3 deep morning sputum samples, it has about an 80% detection rate.
But what if they can't produce sputum, or we need to stage the lymph nodes in the center of the chest?
Then we use EBS endobronchial ultrasound with transbronchial needle aspiration. This is a total game changer. We run a flexible bronchoscope down the trachea, and at the tip, there's a tiny ultrasound probe.
It's like using sonar to look through a wall.
Exactly. From inside the airway, we can literally see through the cartilage rings right into the mediastinum to evaluate the subcarinal and paratracheal lymph nodes.
Wow.
If a node looks enlarged or suspicious on the ultrasound, we pass a tiny needle right through the airway wall, aspirate cells from the node, and pull it back. It gives us definitive tissue staging of the mediastinum without having to crack the patient's chest open.
That is amazing. But what if it's a peripheral adenocarcinoma? The bronchoscope can't reach the tiny outer airways, right?
No, it can't. For peripheral lesions, we use a CT-guided percutaneous needle biopsy.
Percutaneous, so through the skin.
Right. The interventional radiologist uses a live CT scan to precisely guide a needle through the patient's ribs, through the pleura, and into the nodule.
Sticking a needle from the outside of the chest through the pleural space and into the lung. I mean, that sounds like a great way to collapse a lung.
It is the major risk. It carries up to a 25% risk of causing a pneumothorax. And here is a vital caveat for your clinical reasoning. A negative biopsy from a percutaneous needle does not definitively rule out cancer.
Wait, why not? If the needle went into the mass and pulled out benign cells, isn't it benign?
Think about the tumor architecture. Tumors often outgrow their blood supply, causing the center to die and become necrotic. If the radiologist's needle lands right in the necrotic center, the pathologist only sees dead tissue.
Oh, I see.
Or they might miss the malignant cluster of cells by literally 1 millimeter and only aspirate the surrounding inflammatory cells. If your clinical suspicion is high based on the patient's history and that spiculated CT scan, a negative biopsy is just a false negative. You must rebiopsy or resect.
Tissue is the issue, right?
Exactly.
Let's talk about the ultimate imaging tool, the PET scan, positron emission tomography. The slides say it measures active glucose metabolism. My misconception as a student was always that a PE scan specifically finds cancer.
That is a very, very common misconception. A PET scan involves injecting a radioactive glucose analog into the blood. Cancer cells divide rapidly, so they are incredibly greedy for glucose. They consume the tracer and light up brilliantly on the scan.
So why don't we just use a PET scan instead of doing those risky lung biopsies? If it lights up, it's cancer.
Because cancer cells aren't the only greedy cells in the body. If you have a severe lung infection, your macrophages and neutrophils are working in overdrive. They consume massive amounts of glucose to fight the infection.
Right.
A fungal granuloma from histoplasmosis will light up like a Christmas tree on a PET scan. Severe inflammation lights up. False positives are rampant. You use the PET scan to find hidden metastases for staging, like a hot spot in the liver or bone, but you still need a microscope to confirm what is actually consuming that glucose.
Which brings us to the TNM staging system. Tumor, node, metastasis. Let's break down the cutoffs, because they dictate whether a surgeon will even touch the patient.
Absolutely. T is for tumor size and local invasion. T1 is a tumor 3 centimeters or less. T2 is between 3 and 5 centimeters, or involves the main bronchus. T3 is larger, or invades the chest wall or pericardium.
And T4?
T4 is the massive danger zone, a tumor of any size that invades critical mediastinal structures like the heart, the great vessels, the trachea, or the recurrent laryngeal nerve.
Okay, then N for nodes.
N1 means spread to the ipsilateral hilar nodes, the
Yeah.
nodes right at the root of the lung on the same side. N2 means it is pushed deeper into the ipsilateral mediastinal nodes. N3 means it has crossed the midline to the contralateral side, or traveled all the way up to the supraclavicular nodes above the collarbone.
And finally, M. M0 is no distant spread. M1 means it is seeded to distant organs, the brain, bones, liver, or adrenal glands. And M1 changes everything.
It does, which leads perfectly into stage-based management. You have the TNM score. You are sitting in the multidisciplinary tumor board. The ultimate defining question you have to answer is this tumor resectable for a cure?
Let's start with non-small cell lung cancer. Early stages, stage 1 and stage 2.
For stage I and II, surgery is the gold standard. The procedure of choice is a surgical lobectomy, removing the entire anatomical lobe containing the tumor, along with a regional lymph node dissection.
Okay.
If a patient's lung function is too poor to tolerate losing a whole lobe, a surgeon might opt for a wedge resection, just carving out the tumor with margins, but a full lobectomy has better recurrence-free survival rates.
And we use adjuvant chemotherapy here, right?
Yes, for stage IB, that's tumors over 4 centimeters, and stage 2, adjuvant chemotherapy is standard of care. We give chemo after the surgery to eradicate any microscopic micrometastases that were invisible on the PT scan. It adds a definitive survival benefit.
What if that stage I patient is that 75-year-old with severe heart failure we talked about earlier? They have a curable tumor, but anesthesia would kill them on the table.
Then we use stereotactic body radiation therapy, or SBRT, like the CyberKnife. We deliver incredibly precise, highly concentrated, ablative doses of radiation to the tumor in just a few fractions. It's highly effective for medically inoperable patients.
Okay, moving to stage 3. The tumor is large, or it's deep in the N2 mediastinal nodes.
Stage 3 is the most complex algorithm. Generally, it requires a combination of chemotherapy and radiation. Surgery is highly debated here and usually reserved for patients where we can do neoadjuvant therapy, give them chemo and radiation first to shrink the tumor and sterilize the lymph nodes, and then go in for the resection.
And stage 4, M1 disease.
Surgery is completely off the table for cure. The goal shifts entirely to systemic management, palliation, extending life, and preserving quality of life.
Right.
This is where precision medicine shines, using targeted therapies for EGFR or ALK mutations, or using immunotherapies like checkpoint inhibitors that train the patient's own T cells to attack the cancer.
Let's explicitly define the hard stops. What makes a tumor absolutely unresectable?
Obviously, stage IAB and stage 4 disease.
Mm.
If the tumor has invaded the vena cava, causing SVC syndrome, if it involves the contralateral lymph nodes, which is N3, or if there is a malignant pleural effusion.
I want to highlight vignette 10 regarding pleural effusions here. You have a 65-year-old patient with a 4-centimeter peripheral mass, but the X-ray also shows a massive pleural effusion, a fluid shadow around the lung. Does that automatically mean the cancer has spread to the pleura, making it stage 4 and inoperable?
No. And you will literally kill a patient's chance at a cure if you assume it is. You absolutely must tap that fluid.
So you do a thoracentesis.
Yes. Perform a thoracentesis and send it to cytology. If the fluid comes back packed with malignant cells, then yes, it is a malignant effusion, it is M1A disease, and surgery is contraindicated.
But what if it's not?
What if the fluid is just an inflammatory reaction? What if it's a parapneumatic effusion from a post-obstructive pneumonia caused by the tumor? If there are no cancer cells in that fluid, that patient might still have a stage 2 cancer, and you could still cut it out and save their life. Never rule out surgery based on a shadow of fluid. Prove it with a needle.
That is a masterclass point right there. Prove it with a needle. Okay, let's completely shift gears. Small cell lung cancer management.
Small cell completely throws the TNM staging out the window. We stage it as either limited or extensive because 95% of the time it has already micrometastasized by the time you find it. It is rarely, if ever, a surgical disease.
If we don't operate, we don't treat it at all, what happens?
Untreated small cell lung cancer has a median survival of about 1.5 to 3 months. It is devastatingly fast.
So what is our weapon of choice?
Chemotherapy and radiation. For limited stage, meaning the disease is confined to one hemothorax and can be safely targeted within a single radiation field, we use concurrent chemo and radiation. For extensive stage, we use systemic chemotherapy, often combined with immunotherapy.
The notes mention a specific intervention for small cell called prophylactic cranial irradiation, or PCI.
Yes.
Let me use an analogy here. Tell me if this tracks. The blood-brain barrier acts like an overzealous bouncer at a nightclub. We pump the patient full of systemic chemotherapy to kill the small cell tumor. The chemo kills the cancer in the lungs, but the bouncer, the blood-brain barrier, won't let those large chemotherapy molecules into the brain.
That's exactly right. The bouncer keeps the chemo out, not realizing that microscopic small cell cancer cells are already inside the club, hiding in the VIP section. Small cell has a massive propensity for central nervous system metastasis. Even if the patient has a complete response in their chest, they will often relapse months later with fatal brain metastases.
So how do we clear the VIP section?
We radiate the entire brain. Prophylactic cranial irradiation. If a patient responds well to the initial chemotherapy, we preemptively radiate the brain to kill those microscopic hiding cells. It significantly decreases the incidence of symptomatic brain metastases and improves overall survival.
Before we wrap up the core material, there is a bonus tumor mentioned on the slides that isn't small cell or non-small cell, carcinoid tumors.
Yes.
Let's do vignette 9. A patient presents with recurrent pneumonia in the right lower lobe. During the exam, you notice intense facial flushing, and he mentions he's been suffering from severe chronic diarrhea and occasional wheezing.
This is a textbook pulmonary carcinoid tumor. It's a low-grade neuroendocrine tumor. Because it grows slowly in the airway, it causes that physical obstruction leading to recurrent pneumonia. But because it is neuroendocrine, it secretes vasoactive substances, primarily serotonin, directly into the systemic circulation.
Which causes carcinoid syndrome.
Right. The massive amount of serotonin causes vasodilation, leading to the facial flushing. It stimulates gut motility, causing the severe diarrhea. And it causes bronchospasm, leading to the wheezing. But unlike small cell, carcinoid tumors are relatively indolent, and the primary treatment is just aggressive surgical resection.
Okay, we have covered an incredible amount of pathophysiology, histology, and clinical reasoning. We've woven the critical board facts and vignettes throughout the discussion today.
We definitely have.
But as we step back and look at the whole picture, what is the ultimate takeaway for a PA student getting ready to walk into the clinic tomorrow?
The ultimate takeaway is that your diagnostic vigilance must evolve. For decades, we have viewed lung cancer strictly through the lens of tobacco. It was a smoker's disease. And yes, smoking remains the undeniable king of carcinogenesis. But the paradigm is shifting violently under our feet right now.
The rising tide of cases tied to PM 2.5 air pollution, these complex occupational synergies, and those unique targetable genetic profiles in non-smokers, it's challenging everything we thought we knew.
Exactly. As future PAs, you are the frontline defense. You are the one looking at the initial chest x-ray for a pre-op clearance or evaluating that persistent winter cough. The question is, will your index of suspicion be high enough?
Right.
When that 40-year-old non-smoking woman who grew up near a busy, polluted highway comes in, will you fight your own implicit bias? Will you dig deep enough to find that solitary pulmonary nodule before it crosses the 3-centimeter threshold? You cannot rely on stereotypes to make a diagnosis anymore. You must rely on the data, the imaging, and a deep understanding of the molecular mechanisms we discussed today.
Thank you so much for joining us on this extensive masterclass today. Keep reviewing those cellular mechanisms, keep visualizing those anatomical structures when you read a vignette, and above all, stay intensely curious, because out there on the wards, when you are staring at that grayscale x-ray, trying to make sense of a tiny coin-sized shadow, your clinical curiosity, your willingness to ask why, is exactly what is going to save a life. Until next time.